record the meeting. And thank you all for being here this afternoon. The sun is shining a little bit in Ohio, so that's great. We're excited for you to join us for this maternal health for the adolescent patient maternal and mental health training. We have Dr. Jamie Macklin and Dr. Catherine So, who will be presenting for us. At this time, I want to thank the Ohio Department of Health for their support with this training and their funding for the Preventative Health Project. As many of you know, we have had many preventative health webinars over the past year, and we are currently in the process of having of our quality improvement project. We have many resources available on a variety of preventative health topics. So I will post that link in the chat box for you all to view. And then there will be one CME credit available for attending this training. And I will send that survey out tomorrow to everyone, and you'll receive a certificate. If you have any questions or need anything throughout the training, please let us know in the chat box, and please keep your lines muted and your cameras off. At this time, I'll pass it over to Dr. Macklin, and then Dr. So will come after her. Thank you all so much.
Hi all, thank you so much for taking the time to be on this training. I know everyone is busy. I know many of the folks on this call are pediatricians that have busy office practices of your own. So thank you again for taking the time to listen and learn in between your patients. My name is Jamie Macklin. I am currently an internal medicine and pediatrics hospitalist. I have practiced outpatient medicine up until about 3 or 4 years ago. Then it got a little difficult to manage keeping up with both inpatient and outpatient medicine in both adult medicine and pediatrics. But I am based out of Nationwide Children's Hospital in Columbus and then the Ohio State University Medical Center. And I'm also the medical director for the Ohio AAP's Healthy Mom, Healthy Family project. And so I was asked to speak on this topic, and it is one that is dear to my heart, and I hope to teach you all a little bit about it, convey some information, and do my best to answer your questions after this is over. I know Alex and Liz will be manning the chat during our presentation, so I won't be looking too much at it during my piece at least, but happy to take a look back and answer any questions in the chat when I'm not speaking during the second half of this presentation. And I think we also might have a little bit of time for verbal Q&A or additional questions at the end. So with that, I will go ahead and get started. Hopefully here. There we go. I have no disclosures. I don't intend to discuss anything overly crazy or funky. Hopefully you will agree by the end of this, but let's go ahead and get going. So here are our objectives, at least for the first half of this lecture, and then Dr. So will be going through hers as well. So by the time I'm done talking at you, my goals for you are to hopefully get a little bit better understanding of the demographics of adolescent births in the United States, learn a little bit about risk factors and complications of adolescent pregnancies. Here's a big one. Be empowered as pediatricians to provide care and promote well-being to pregnant adolescent patients. And I know for some of you, that might be a big ask, and we'll certainly talk a little bit more about that in the presentation. And the last one is then to gain knowledge of practices that you as pediatricians in your offices can use to support your adolescent patients and families in the postpartum period and beyond. So care for the pregnant adolescent patient both during pregnancy and following the period after the child is born as well. So let's get going. So talking a little bit about the issue, what does this look like nowadays? So in 2020, which is the last year that the U.S. Department of Health and Human Services mentioned, the teen birth rate was 15.4 births per 1,000 females aged 15 to 19 years. And again, they don't necessarily clarify a lot before age 15 years. So the whole, 11 to 14 years is not as well clarified or quantified, but at least for the older adolescents, 15.4 births. This equals out to about 160,000 teen births in 2020. This is down from the year before, thankfully, about 8%, and down a good deal from about the time they started tracking teen births back in the early 1990s. I will throw in just a brief comment. Approximately 15% of these 158,000 teen births were not first births, meaning that these teenagers had a previous child before the birth that is logged here. So again, this is just a figure kind of stating as such, broken down by race and ethnicity. You can see again the general decline over the past 30 years in adolescent pregnancies and births. Again, the overall total being the broken up kind of navy blue line. They're near the third from the bottom. You can see the U.S. Department of Health and Human Services has further delineated over the past 10 years rates for American Indians and Natives, Native Hawaiians and Pacific Islanders, and then the Asian population as well. But just to give you an idea of what we're looking at here most recently. So risk factors for adolescent pregnancies. And before I go further, I will say this obviously, as I'm sure you well know, can happen to any teenager. I mean, we list risk factors here and those to watch out for. But much like anything, this can obviously be seen in a teenager that has none of these risk factors. But the ones that we know from studying and looking at epidemiological data are teenagers that live in poverty or below the poverty line. Those that have a teen mother themselves, a single parent home, frequent family conflict, early sexual activity, of course, early use of alcohol and drugs, illicit drugs, low self-esteem, and then race and ethnicity, as in the previous slide. We also know, of course, that there are complications associated with teen births. And certainly, again, there can be complications with any pregnancy, but things that we see maybe a little bit more often with this patient population. So I will start by saying we know from studies that there is an increased risk of preterm birth. And there's a little bit of debate, which I'll discuss here in a minute, on whether there is a biological basis or not. And again, we'll get into that. But biological factors that are thought to be related to the risk of preterm birth include a shorter cervical length compared to mothers that are older, an increased prevalence of lower genital infections overall in the teen population, as well as their own developing reproductive organs, those that are not completely developed and mature. There is an increased risk for low birth weight infants and an increased risk for infant mortality. And we see this in all stages of the early neonatal, those babies that are born 0 to 7 days, late neonatal 7 to 28 days, and then the post-neonatal deaths, those age 1 month to 12 months of age, higher rates of infant mortality in this population. So thinking about maternal complications as well, we mentioned those that are specific to the neonatal populations, but certainly these adolescent mothers have their own complications. And we know that there are increased risk of gestational hypertension, preeclampsia or eclampsia, obstetrical lacerations, postpartum hemorrhage, and then anemia, thought to be due both to physiologic dilution and then iron demands of the developing fetus. And this is where I get into, where I briefly mentioned, we talked about, yes, there are increased complications in teen pregnancies with adolescent moms. And it's a little bit hard to parse out looking at all the different sources of data, whether this is due to biological immaturity, as mentioned 2 slides ago, or if it's related to poor socioeconomic environmental factors, or both, which is probably the most likely or most plausible reason for this. There's obviously a lot of factors involved with teen births, adolescent pregnancies, and all of the aspects and all of the things that are stewing related to these probably lead to all the complications, some form or fashion. But just be aware that debate is out there. No one is 100% entirely sure, but suspect there's more than one issue at play. So whenever I told my pediatrician friends at work a few weeks ago, I was working on these slides. A few of them stopped by my office, asked what I was doing, and I told them what I was working on. They gave me these horrified looks and said, "We don't manage pregnancies. We're pediatricians. We're not OBGYNs. We're not family practitioners." Yes, This is true. I totally understand that. I know I am not lecturing to OBGYN residents or family medicine residents. I get it. I know you all are pediatricians, but you are, by nature of your training, optimally trained to provide comprehensive care for all kiddos on the age spectrum. So infants, children, and adolescents. And you as pediatricians, we, I guess, including me, probably better than any other specialty, understand the importance of creating a medical home for all patients. I think pediatricians are so very good and so very well trained about how to create a medical home and a safe place for patients and their families to come and receive care. This includes the adolescent parent, whether we feel comfortable with that completely or not. And again, my goal is to help you get a little bit more comfortable with this. But you actually fit right in as a pediatrician. Now, before I go further, I will say that the rest of this lecture is not going to be spent on providing obstetrical type care to your patients. I do not expect you to be able to measure fundal lengths or cervical changes or all of the other things that are involved in obstetrical care of a patient, adolescent or not. We're not going to be discussing that. But you can play a role in the care of these patients during their pregnancies, even if you're not involved with all of those other obstetrical type things. And so let's talk a little bit about what that looks like in your role as a pediatrician. So how might this start for you? Identifying the pregnancy. Yes, there are home pregnancy tests, and maybe that might be the way that your adolescent patient finds out they're pregnant, or the parents or the patient might come to you and say, I've been having these symptoms. They might describe something to you that, well, maybe this is a pregnancy or not. We all have low thresholds on what this might look like: missed periods, nausea, breast tenderness, a number of factors. So it would be up to you to take the history and get some knowledge before diagnosing. And obviously, in addition to discussing, the physical signs, excuse me, including those I just mentioned, maybe asking your patient some of these questions. Has your patient ever been involved in a sexual relationship? Who is or are her partners? Is there any history of sexual assault? That's an important one to obviously tease out early on. Any prior pregnancies? Would this be a pregnancy she would want? Important to kind of suss that out as well. Has your patient already considered how she might manage a pregnancy if that test is positive? Would it affect her living situation, plans for education, plans for employment? What would that look like if a pregnancy test you got in your office was positive? What would that do for her? Any supportive adults in her life? Again, if this test is positive, who will be her supports? And if the test is not positive, would she like to begin a more effective contraceptive method? And that might be your way in to discuss some contraception in the future, if not. But again, some questions to think about and ask if you have a patient that presents to your office with certain symptoms that you kind of, scratch your head and think, oh, could she be pregnant? If the pregnancy test is positive, so the family might come to you and say, what are our options? This might occur at the visit if the test is positive, or if families want to come back, it might occur at a subsequent visit. Hopefully she will have other supports, whoever those might be, based on who you've identified with her. I am not going to get into a big political conversation in this training. I will say in Ohio, the options right now are carrying a pregnancy to delivery and raising the infant, or carrying the pregnancy to delivery and making an adoption or kinship care, someone else that would be able to raise the child. So it would also be prudent for you to refer her to prenatal care ASAP. And again, something I'm sure you would consider if the pregnancy test was positive in your office during that initial visit. But obviously, early prenatal care can reduce medical complications of the teen pregnancy. Some obstetric providers even have added expertise in teen pregnancy, and some of you might know who those providers are in your community. But even if not, getting her to see a family medicine specialist or an OBGYN based on her preferences. And again, you might be the one to go through what that would look like. But then getting the teen ideally back to you as the pediatrician following the pregnancy. Considering nutritional supplementation. And again, this would be something that you would do alongside with referring to obstetrical support, but having that conversation during the visit as well. We know that there is certainly a competition for nutrients between a mother and fetus, any age mother, but certainly a teenage mother who is undergoing her own development as well. There is a high prevalence in nutritional deficiencies in adolescent. I mentioned calcium, iron, zinc, certain vitamins, folate, obviously, are the big ones. And certainly, most of the time, this is related to a poor diet in the mother, teen or not, and then a poor knowledge of appropriate nutrition. These are all factors that might at least have you considering some kind of nutritional supplementation. If you don't feel a vitamin is needed, I know there's different trains of thought on vitamins. We here at the Ohio AAP do recommend, vitamin supplementation, a prenatal vitamin, but at the very minimum, please consider at least dietary education for this teen mom in boosting the amount of nutrients, specific nutrients based on what I've listed here that she receives during this pregnancy. Advising tobacco avoidance and cessation. We know through studies that adolescent girls that are more likely to smoke and drink alcohol in pregnancy than women in other age groups. There is a link to prior use of alcohol and or cigarettes. This is associated with increases in sexual risk taking, which leads to increases in unplanned pregnancies. So it's imperative to screen teens for tobacco and alcohol and or illicit drug use and assess the readiness to quit. This pregnancy could be a great motivation to quit, and certainly you would play a key role in trying to facilitate that for her. An easy way to assist with this, or I guess maybe a less complicated or easier way, I should say, would be referring to the Ohio Quit line. I suspect many of you have likely used this in your practice, but if not, the number is listed here. It's 1-800-QUIT-NOW. This automatically takes you to the national quit line, and then you or the patient, whoever calls, but then that automatically gets rebounded to the state of origin, so Ohio for us, obviously. They also have a chat function on the website, so if the teen or whatever doesn't feel comfortable talking to a live person, they can web chat. But participants will work with a quit line coach over the course of their quit journeys, however long that takes. I did confirm with the quit line before this presentation, they have worked with pregnant patients. They have worked with teen patients. They've worked with all different not kinds, but all different races, ethnicities, ages, different situations, and would be comfortable with working with a teen pregnant patient on smoking cessation. So that is certainly an option, and certainly something to screen and look for in your pregnant teen patients. And then assessing support and a link to resources. And again, this might be where if you know a social worker or if you have a social worker based in your clinic, they can assist as well. But the pregnant teenager, any patient might need assistance with transportation, housing, accessible food, any community-based options for adolescent parents that you can think of or get would probably be useful. We see a lot of use in school-based or home visitation programs. We know through studies these have been linked with reductions in subsequent pregnancies, government assistance, child abuse and neglect, and the criminal behavior in adolescent mothers. They can also reduce the risk of antisocial behaviors and substance use by children born to adolescents. I will highlight the use of home visiting programs. The one specifically that I'm a little bit more familiar with is the Nurse Family Partnership. I would also recommend considering Head Start or Early Head Start for the child born to your adolescent moms as well. And again, there's many other programs. I just throw a few of the more common ones or the ones that I'm a little bit more familiar with out there. But certainly a lot of options there, based on what you know of in your community. And again, a social worker, if you have one available, could be a great resource here. And then something I suspect many of you are familiar with, but meet the pediatrician visits. And again, these are optimal for not just pregnant teenagers, but any woman who's pregnant. But optimal for a will-be mother, his or her partner, and ideally a trusted family member, maybe the teen's mom, maybe the potential, the dad's mom, anyone else that's going to be a support, to schedule a prenatal visit with you during the third trimester. This is a great time for you to assess family resources, as in the previous slide, assess parental well-being, how are things going, meeting extended family members, and addressing those support system. Again, who's going to be helping mom out with this baby? Discuss breastfeeding decisions. Has mom thought about this? How will she feed the baby? Answering questions. And again, starting that transition of the adolescent mother back to the pediatrician following delivery of that child. So we've discussed a whole lot of things that you as pediatricians can be involved with and assist with during the pregnancy. Shifting to what happens after the pregnancy. Well, there is still a lot of ways that you can be helpful. And again, I know you're not OBGYNs, but certainly you will be valuable assets for the adolescent mother and her child, following pregnancy. So a number of ways. First one, probably the most obvious, is continuing care and well visits for both the adolescent mother and her child. You can perform psychological or depression screenings, discuss contraception planning. Now that the pregnancy is over, how will she work to prevent a second or third or what have you pregnancy? Counseling on safe sleep practices, maternal educational plans. I know some pediatrician offices have set up teen tot visits, meaning dual appointments for both the adolescent mother and her child, to discuss all of this, the comprehensive care involved in one visit. Might be something to consider based on your patient population and the needs for your specific community and practice. Again, managing contraception. There is a significant association between repeat adolescent births and decreased educational achievement, increased infant mortality, low birth weights. And again, if we worry about one pregnancy affecting the adolescent's life course as far as employment, education, educational efforts, a second pregnancy would be, but could potentially be even more hazardous to health and then the socioeconomic trajectory going forward. So offering counseling and referrals is necessary for desired contraceptive methods in the immediate postpartum period. The AAP in general focuses on LARCs, so the long-acting reversible contraceptive methods, primarily IUDs and implants. But again, whatever the adolescent mom would like to be on, what will probably be the best option, considering breastfeeding as well. But again, something to discuss and consider whenever you see that adolescent mom back in your clinic. Encouraging breastfeeding. Again, we know there's health benefits for both moms and babies. I know you all are aware of those. It's cost effective. So thinking specifically of the teen mom, it's cost effective. This may result in longer interpregnancy intervals, and may foster mother-infant bonding as well. So certainly just as beneficial, if not even more, in this population. We do know that adolescent mothers are less likely to initiate breastfeeding than older mothers, so might need that little extra push or assistance or encouragement from you. So certainly a topic to discuss in certainly early well visits or in the meet the pediatrician visits that we discussed in a previous slide. But you as the pediatrician can provide lactation support either in the office, through a telephone support program, or can refer to lactation counseling outside your office. Whatever you would normally do for your non-teen mothers should certainly be done enthusiastically for your teen moms as well. Because again, many benefits here for breastfeeding in this patient population. So we talk a lot about teen moms, obviously in this presentation, which is it's generally geared toward that. But I think we would be remiss to not mention the teen dads as well, who are undergoing big changes as well in their lives. Estimated that 20 to 30% of teen pregnancies also involve teen fathers at the time of birth. So again, a fairly significant percentage here. However, there is little research or attention that generally exists on adolescent male fatherhood. Again, we focus a lot on the moms, not as much on the dads. However, pediatricians can change this a bit and can encourage adolescent fathers to play a role in their child's lives, promoting equal parenting and as much as possible, and providing community resources, that we mentioned for the teen moms, for the teen dads as well. We do know that children of, or infants to children of teen parents tend to have better outcomes going forward in employment, education, mental health, and they are at lower risk of becoming adolescent parents whenever the dad is involved. So it would certainly be helpful and would your assistance would span multiple lifespans if you can work with and encourage teen dads as well to be involved in their child's care. You can also screen for intimate partner violence. We know the intimate partner violence, or IPV, on the slide amongst adolescent mothers is 7%. This is a fair amount higher than older mothers. So I mentioned the 2% statistic here, and can be normalized by the adolescent's own childhood violent experience. If the adolescent mom is used to seeing her own mother or sister or what have you undergo intimate partner violence in some form or fashion in the home setting or close to it, she might just be used to it and think that's how things are supposed to be. This is normal. We know otherwise, and so you can help screen for that and get her resources if screens are positive. And there are multiple screening tools that exist. I've mentioned a few here on the slides. Again, I think you're getting a copy of these slides from what I hear whenever we're done. Maybe something to Google and see if you'd like to put this into your practice if not already done. I will specifically highlight this AAP clinical report. This was in pediatrics. It's been revised a number of times over the past 30 or so years. The last revision was 2 years ago. I've listed the link for it. I also sent this report to Alex and asked her to send it all to you. Just that way, if you don't have a subscription or what have you, you can have access to it. It is a great comprehensive report on how to care for these adolescent parents and their children, kind of focusing on a number of things that I've spent time talking about in these slides, but even more topics in addition to that, and then in a little bit more depth. The thing that I also like about this report that I did not include in these slides, they have a specific section at the end called Guidance for the Pediatrician. And it's 16 steps to making your practice or office ready to provide a holistic medical home again for your adolescent parents and their children. So even if you can't do all of the 16 steps, do one or two of them. And that's a start and certainly an improvement to where maybe things were before. But I will have her send that report to you whenever you get these slides as well, so that you can refer to it the next time you have a pregnant patient or an adolescent parent in your clinic. So the last thing I will mention that you as a pediatrician can do is that you can manage mental health concerns, both before and after the pregnancy. And so for that, I will turn this over to Dr. Catherine So, who is an expert in this area and who's going to be talking to you a little bit more about this specific topic. So with that, I will stop sharing my screen.
Thank you, Dr. Macklin. That's so wonderful.
Thank you.
All right.
And again, I will look for questions in the chat whenever she's talking. Thanks all.
All right. Can you all see the screen and hear me? All right. So I'm Katie. So I am a triple board trained, so in pediatrics, adult psychiatry, and child and adolescent psychiatry. And I work at Cincinnati Children's doing pediatric hospital medicine half the time, and then as a consultation liaison child psychiatrist half the time. So excited to be here to talk with you about perinatal mental health and kind of build off of what Dr. Macklin has spoken about earlier. I don't have any disclosures either. We will start off with some background epidemiological information, talk about the signs and symptoms of perinatal mood disorders so that we can feel confident in recognizing depression and anxiety in the perinatal population early. we'll talk about initial approach to management of these illnesses, when to involve subspecialists, and then some resources that hopefully you can refer to and find helpful later. So perinatal depression is very common, unfortunately. 1 out of 7 women experience this. And so if you have teens in your clinic who are pregnant or are mothers, 1 in 7 of those probably have experienced this. And it's actually twice as common as gestational diabetes, with up to 7% prevalence. And mental health conditions, including suicide, are actually a leading cause of pregnancy-related deaths. So symptoms can actually start. A lot of people have depression or anxiety before they're even pregnant, and then number of them can develop it during pregnancy, which will be up to 20% of pregnant women. And then about half of those will have symptoms persist postpartum. And when we talk about perinatal depression, we're talking about kind of during pregnancy and then up to a year afterward. Just as Dr. Macklin was saying, fathers also kind of share in this experience, and up to 10% of fathers will experience depression and anxiety in that perinatal period as well. And for them, it has been shown that this often manifests as impairment at work or in function, as well as substance abuse. I wanted to also mention perinatal anxiety because this is also common, often comorbid with or a strong predictor of perinatal depression, and just isn't talked about quite as much. Oftentimes, the people who experience this have a pre-existing anxiety before they're pregnant as well. Up to 20% of those patients will experience it both prenatally and postnatally. And just like perinatal depression, which we'll talk about more, anxiety can have adverse perinatal outcomes as well. So this would include poor nutrition, substance use, less likely to seek medical care, and insecure mother-infant attachment, which can have huge impacts on mental health resilience for the child's lifetime. Adolescents in particular have especially high rates of depression, up to 44% in this perinatal period, and are more likely to have these symptoms persist postpartum as well. They are more likely to experience suicidal thoughts. The suicide attempt rate in this population is 9% in studies. Those who experience perinatal depression have higher rates of substance abuse, which can be up to half of the population. And they also tend to have harsher parenting styles. The adolescent pregnancy population tends to have a 2 to 3-fold rate of victimization from either their partners, their families, the father of the baby. And so they are at much higher risk of PTSD or post-traumatic stress disorder as well. And they actually have had studies that on average, teen mothers experience 5 or more traumatic events. So it's quite high and important to have that safe space to talk about in your office as well. This population is more likely to experience financial stressors, have limited social support, and be from families with lower educational attainment or employment. They are disproportionately African American and Latina as well. And importantly, though, you can actually have positive outcomes akin to people who have children later in life, if they have strong social supports. And so there's a huge emphasis on strength-based focus and making sure that we can help support them from a social and functional aspect as well. So why are we talking about this is because perinatal depression can have huge impacts on birth outcomes and actually lifelong outcomes. So there's an increased risk of both maternal and infant morbidity and mortality with perinatal depression. From the maternal perspective, there are higher rates of miscarriage, preeclampsia, C-sections, more difficulty supporting breastfeeding, as Dr. Macklin referred to. For the babies, there's a higher rate of low birth weight, preterm birth, NICU stays, developmental and cognitive delays, and behavior problems. There's more likelihood of toxic stress, and this is linked to insecure attachment, which is huge. And interestingly, there's actually some studies that show that adolescents who have been born to mothers with perinatal depression have higher cortisol levels in those teen years. What are some of the symptoms that we look for in perinatal depression and anxiety? So some are, as you would expect, persistent sadness, irritability, poor concentration. Some people just have a lot of trouble making decisions. There can be anxiety around the infant, or feeling guilty, or feeling like you're not a good enough mother. There's a lot of apathy toward family, the infant, or prior enjoyment, and that would be a kind of red flag that you could note. Suicidal thoughts, obviously. And then racing thoughts, not sleeping when you're actually able to, so not because the baby's crying. With a distinct mood change might be an indicator of mania. So I just wanted to make sure you're aware of that as well, because that can happen in this postpartum period. How do you distinguish if it's the baby blues or depression? So baby blues are typically up to 2 weeks. People are emotional with the hormonal changes and their mood can be labile. Depression lasts over 2 weeks by definition. There's a lot of guilt, worthlessness, functional impairment is always key to if something's pathological or not. And then suicidal thoughts would also be not normal in baby blues. I wanted to quickly mention postpartum psychosis because it is something that I would want people to be aware of and know to refer to emergency care. This can happen in 1 or 2 out of 1,000 live births, but it has a very high correlation with bipolar disorder and often is an indicator of an underlying bipolar disorder. Typically, it can happen between like hours to up to 3 weeks postpartum, characterized by hallucinations, bizarre delusions, disorganized thought process. Something that you can help with is, the medical care is to rule out delirium due to a medical cause, whether that be an infection or something else that they've been exposed to. Sleep is incredibly important in this population. And importantly, infanticide can occur in up to 4% of those with postpartum psychosis. The treatment is electroconvulsive therapy and mood stabilizers, and it is worth considering preventive mood stabilizers during their next pregnancy because there is a very high rate of recurrence of this. Some of the risk factors for perinatal mood disorders, as with most illnesses, is a history of depression and anxiety or a history of mood disorders, family history of this, hormonal mood changes like related to their menses, substance use, trauma, feeling socially isolated, financially stressed. And infant colic is another one that if you have a baby that you're seeing in clinic who has colic, it's really important to ask how the family is doing as well. Risk factors for suicide, especially our history of suicide attempt, especially with and especially lethal means, having a recent attempt, having a current plan of how they might take their own lives or intent. And so if someone is, says they have had suicidal thoughts, it's always important to ask if they have a plan or if they would actually act on those thoughts. Substance use, which lowers your inhibition, is another risk factor, and poor social support. So something that you can do to have a huge impact on catching these early and helping people get treatment early is screening, because as we said, this can affect outcomes. 80% of those with maternal depression are treated by primary care. And as we talked about, the fathers can experience symptoms as well. And so it's important to screen them both if they both come into your clinic or both of the parents, whichever gender. There's actually a recommendation for primary care providers to screen postpartum, and it's considered a pediatric service that you may be actually be able to bill for. So that may be helpful as well. There is a trial called the STAR-D child trial that showed that there was decreased maternal depression severity associated with so basically, if you treat maternal depression, you can help lower the child's psychiatric symptoms at a year and improve their functioning. As far as screening, the most important will be your history. There are a couple of validated screeners, those being the Edinburgh Postnatal Depression Scale, which is a 10-question scale that you can add up in the office. It also screens a little bit for anxiety and is available in Spanish. And then there's a scoring interpretation at the end to indicate how likely they are to be experiencing depression. The PHQ-9 or the Patient Health Questionnaire, which has 9 questions, is another quick, fairly easy screener to administer in the office. If you're looking to screen specifically for perinatal anxiety, there is this PASS scale that's 30 questions. So it takes a little longer, but is available as well. If someone has a history of a mood disorder, or you're worried about some of those, not sleeping, racing thoughts, sort of bipolar mania type of symptoms, you can screen for bipolar disorder with this questionnaire, referred to the ER. So when do we refer, or when do we consider something an emergency? As if there are active suicidal thoughts, especially with a plan or intent, psychosis. Importantly, if you can keep someone in the room with the mom and baby, if you have a concern for this while you work on connecting them to emergency services, that would be really important. So if you are concerned that someone has a perinatal mood disorder, you first want to assess their risk. So is it an emergency? If they're low risk and experiencing some of these symptoms, but it's not impairing their function, they're not suicidal, you can refer them to therapy first before talking about medications. A couple great resources for therapy that we often suggest are psychologytoday.com and Mindfully. Those are just like search engines for therapists. They can put in what type of therapy they're looking for, or sometimes the insurance that they have, their region or location, and narrow it down that way. If somebody has at least moderate to severe depression or some functional impairment, comorbid anxiety, it's worth talking about the potential benefits of medication and how that might weigh with the risk of untreated mental illness. And we'll talk about more of that in a minute. Importantly, when you are talking about medications with people, set them up for, if you feel like something's not working, or if you feel like you're having side effects, please call me before you stop it, before you change the dose, so that we can talk about that together and do it safely. Antidepressants are going to be the most common medications prescribed in pregnancy for perinatal depression. Typically SSRI, there's selective serotonin reuptake inhibitors. The most probably common and with the most best safety profile are probably sertraline and escitalopram. And those are also fairly safe, shown to be safe in breastfeeding as well, which we'll talk about more in a minute. The drug concentrations are lower in pregnancy due to that higher volume of distribution. And then after the baby's born, drug concentrations can significantly increase in the mothers. And the babies, on the other hand, when they are born, will have a significant drop off as far as their serum levels, because they're no longer going to be exposed. So we can see consequences of both of those things. Importantly, with antidepressants, there is no increased risk of, this is specifically SSRIs or SNRIs, no increased risk of miscarriage or stillbirth. That's been shown in kind of the more recent studies. There's no significant association with cardiac defects. And they actually found that SSRIs to treat depression during pregnancy lowered the risk for preterm birth. There have kind of repeated studies that have now shown that there is not an association with persistent pulmonary hypertension and no more problem behaviors with autism and neurodevelopmental orders due to the SSRIs. There are some reports of people saying that there's more preterm labor, prematurity, or small for gestational age prevalence on when babies are born to mothers who have been on SSRIs. However, those studies have not actually been able to distinguish if this was confounded by maternal mental illness. So they kind of need more studies to really tease that out. Neonatal adaptation syndrome is somewhat similar to neonatal abstinence syndrome or opioid exposure, but with SSRIs, and it tends to be much more mild than that. But you can see some of the same symptoms, including irritability, hypertonia, being a little jittery or tremulous, some trouble feeding, and transient tachypnea or respiratory issues. These tend to be not last very long. You kind of just do supportive care for these babies. There's no specific medications to mitigate these symptoms. You just swaddle, feed them frequently. The mean length of hospital stay for babies that experienced this is really just 2 days. So not that different than your typical newborn care, but it's something to be aware of. And that's, again, because they were exposed to SSRIs in utero, had that certain level, and it steeply drops off when they're born. For patients who are on medications for depression, anxiety. So the SSRIs, you don't have to monitor anything specific. However, those that are on antipsychotics, so that would include things like olanzapine or risperidone, you do have to watch out for metabolic side effects, especially, and it can increase the risk of gestational diabetes because of this. And this is important, you know, even if you have patients who are not pregnant on these medications, you monitor the same things. But you monitor liver function, that's how it's metabolized, the hemoglobin A1C, fasting lipids, their weight. There's a lower likelihood in the second generation antipsychotics of extrapyramidal symptoms like stiffness. But if they were to experience this, you would want to obtain a creatine kinase or CPK. Some people are on antiepileptics for mood stabilization. Lamotrigine is one that you may see people on. With this, you watch out for a Stevens-Johnson rash, and that would be an emergency. These are all, you know, monitored or metabolized by the liver, so you always monitor liver function. With valproate, you know, this associated with like neural tube defects in the babies, so probably you won't see many pregnant moms on this, but if someone's on it, you do have to watch out for pancreatitis, especially. There's a black box warning for that. And each of these you can get levels as well if you're worried about toxicity. Lithium is one that you may have heard about more. It's a very effective medication, but does come with more monitoring because it has a narrow therapeutic index. And so you monitor creatinine, thyroid, and CBCs. And this is in the babies, you would monitor this as well. So if the mom is on antipsychotics, you want to also watch for sedation, actually, because this can be sedating. And you would want to watch for a rash if the mom's on lamotrigine. You would want to watch for monitor thyroid levels and creatinine for those on lithium. How long do moms need to be on pharmacotherapy if they have perinatal depression or anxiety? We generally will say 9 to 12 months after they're doing well. So we want you to be feeling like your normal baseline self for a good 9 to 12 months before we talk about slowly tapering off the medication, because we know that stopping these early can increase your risk of the symptoms returning and being harder to treat later. The relapse risk is also higher if you have severe symptoms or multiple episodes of depression. For those who now are on a stable regimen, their mood is stable, and they are breastfeeding or wanting to breastfeed, they might ask you, how safe is it for my baby to be exposed to these medications? And really, the bottom line is that treatment typically will outweigh the risk of untreated depression or anxiety or psychosis. And the risk of not breastfeeding also is another contender. So there are a lot of safe options that people can be treated with and breastfeed. And really the plasma levels of like all these antidepressants and anxiety medications are really low in the children, and typically don't have any kind of long-term effects. And so for SSRIs, the most common, just as in pregnancy, are sertraline and escitalopram, have the best safety profile, not really anything you need to monitor. The probably most symptomatic time they'll have is right when they're born, like we talked about. But generally, there's really no effects to them. Antipsychotics, especially second generations, are probably what people will be on because of the better adverse effect profile. Like I said, you can have some sedation with breastfeeding, so that's something to monitor for. But again, they tend to be very well tolerated, have very low levels in the infant, and sometimes not even detectable. So it's generally recommended to stay on these medications because we know that having a mom who's doing well will have the best outcomes for the baby and their attachment as well. Anti-epileptic mood stabilizers, we talked a little bit about as well as far as what to watch for. And lithium, you can still take while breastfeeding as well, but like I said, you want to monitor the creatinine, the thyroid, and if you're worried about side effects, you can obtain a level as well. There are two databases that I want to point out. The Lactamid database is a fantastic resource that you can look up really any medication, like psychotropic medication, and read about the safety profile for this in breastfeeding. And that's free to everyone. There's an app that's free as well. Group Rotox is another one that's a little bit more research heavy, and it is free to trainees, but once you're out of training, you do have to pay for it. So I wanted to mention some specific teen program interventions, and Dr. Macklin spoke about this teen top model. Home visiting is another one that is can be a great option for these teens, and that would be like it actually has been shown to improve empathy and emotional support and help the mother attend the needs of their child. The Young Parenthood program and Strong Foundations are both co-parenting programs. And so this Young Parenthood program has 10 sessions for the teen parent couple to focus on building communication, self-regulation, interpersonal skills, and has been shown to lead to more positive parenting, especially among the fathers. And Strong Foundations is a prenatal and postpartum adolescent group sessions that is integrated into the Well Child Check. If you're able to have that in your office, and it works on teaching communication, conflict management, and developing one's identity as a co-parenting team. When do you want to refer to psychiatry? Is if someone has severe symptoms, suicidality, you have any concern for bipolar disorder, psychosis, if they're on some of those high-risk antipsychotic medications or anti-epileptics, for mood stabilization, or you're out of your comfort zone. And these are some great resources that we like to make sure everyone is aware of. So the crisis, there's instead of 911 for mental health, there's now a 988 crisis line that's 24/7 you can call. Postpartum Support International has a perinatal psychiatric consult line that is fantastic as well. They also have some free materials. McPap for Mom is out of Massachusetts and has a lot of fantastic materials, mother to baby. There's also information pamphlets that you can print off for depression and anxiety to give to your patients. ACOG, as you know about as well, and those databases are on here. So in summary, hopefully you now are, you're probably already aware that perinatal depression and anxiety are quite common, can affect both maternal and infant health outcomes. You can screen and have a huge impact by just being able to screen for these and talk about them with your patients in the clinic, especially those teenage patients. Treating these can improve outcomes for both the mother and the baby, and there are a lot of resources available, so you are not alone in approaching this. Overall, the goal is maternal euthymia and optimizing the outcomes for the mom, the baby, and their family. So thank you all for inviting me to join you. If you have questions, my email is here. And we also have some Ohio Department of Health resources and our references. Thank you very much.
Jim, Star, is there?
Great, thank you. There is one question in the chat box here. Do we need to worry about abrupt cessation of med in the baby and moms that are on the way, that are on any high dose meds for anxiety, depression, psychosis?
It
looks like the abrupt cessation.
In what
of
context?
any meds.
Yeah, so you can experience withdrawal symptoms with some of these medications. So I would say, yes, they can feel kind of flu-like symptoms, as common with SSRIs if you stop them abruptly. This is more so for the moms, and antipsychotics, you can worry about some of those extrapyramidal effects showing up if you stop abruptly. The babies who have been breastfeeding and getting this, I think you're probably unlikely to really see any big effect, but it would probably be like a milder form of that same thing that the mom experiences. Sort of similar to like when they're abruptly no longer exposed to it when they're born with SSRIs, something similar to that.
Great, thank you. We can open up if there are any more questions to chat in, or if someone wants to come off of mute and ask their question, I think we can do it that way as well. Okay, give a few more moments here, and then I think we would be good to wrap up and talk next steps. Okay. Well, thank you to Dr. Macklin and Dr. So. This was an incredibly informative presentation. It was recorded, so we will go ahead and add that to our robust repository of education, and you will receive an email from Alex Miller following this presentation with the information for CME and evaluation and the attachments that Dr. Macklin was referencing in her presentation, as well as access to the recording and slides. And I think that's all I have. Alex, did I miss anything?
No, that's perfect. Thank you so much, Dr. So and Dr. Macklin and everyone for joining. We had a great turnout today, and thank you so much to Liz for helping with the chat and sharing all the information. I will also send the links to the resources that were shared in the chat box with the email that I send out tomorrow. So please let me know if there's any questions. Have a great day, and thank you all so much.